diluted by an uncle system.
Members, can we, members, can we?
Over here. Technical and statistical subgroup.
Yes.
We've now got a second presentation, a strategic overview of immunisations in Birmingham. And we've got Mary O'Reilly, Assistant Director of Public Health, Paul Sherry, Chief Officer of Partnerships and Integration on the Integrated Care Board, and Leon Mallet, Head of Immunisations and Vaccinations. We've got about 40 minutes for this item, so if we could keep the presentation to about 50 minutes, and then we can have 25 minutes for questions.
Thank you very much. So I'm Mary O'Reilly, AD Public Health, and with me today I've got my colleague Leon Mallet from the NHS, and I do emphasise it's colleague, partner, because we very much work on this together, and Helen Bissett, who also does much of our immunisation work here at Birmingham City Council. So I'll just whiz through the presentation and then, as I say, leave a bit more time for a bit more. So the background of this really is that immunisation, our focus on immunisation, is delivered to people who are well. And it's part of an ongoing protective strategy, protect and prevent the need for healthcare, and it's relevant to all people, all citizens. It's also one of the most effective and evidence-based public health measures that we have. And sometimes because we know that, and it's been around a long time, it's not new and glamorous, sometimes it's a bit, oh gosh, it's immunisation again. So the purpose of this particular conversation, being here today, is that we want to give you a brief strategic overview, but we'd also like to hear back from you, because we intend to come back in April with 2 further papers, one from Public Health and one from the Birmingham Solihull Integrated Care Board, that will give a bit more detail, but it'd be useful to have some feedback from you today so that we can make sure that we've addressed all the concerns and any issues that you wish to have explored. So, we felt it was important really to touch on our system roles, and this is very much one of those that is accomplished working. So the setup that we have is, and I know this is rather small, but the Secretary of State for Health and Social Care gives responsibilities in a number of different directions. So to NHS England to commission immunisation, to the UK Health Security Agency to do the surveillance of vaccine preventable diseases, the policy and the planning, JCVI, which is slightly out to the side, who are our wise men and women, giving us information about what will and not work, and that's given to government. But then lower down at an operational level, we've got very much NHS England, who will commission and deliver much, but not necessarily all, of the immunisation that's required. So moving on, just exploring our NHS system role in a bit more detail. So just to be really clear, the NHS is responsible for commissioning immunisation services. NHS England is responsible for commissioning immunisation services, and they have primary responsibility for immunisation uptake. Now, perhaps you may all know, but just to absolutely clear, the immunisation, the significance of immunisation is that we give vaccination to people, but we want them to then develop immunity. And that's a distinction between immunisation and vaccination. I'm aware that some of these, this may be picked up elsewhere. So you may all know that, but I just needed to clarify. That means that when we give vaccination, the goal of immunisation, if that goal is not achieved, it's immunisation of a population. So we immunise an individual, but we also want to immunise a population. What we've got at the moment is immunisation of many individuals, but not sufficient immunisation of our population. ICB also has oversight of the programme deliverables. So those are, you know, who's doing what and how many of them and in which different sections of our city. And they lead a number of boards, including an all-age immunisation and vaccinations programme board, in which public health and other partners and colleagues are represented. The public health role within this is that the Director of Public Health has a responsibility to be assured that there are sufficient, adequate plans in place to protect the health of the population. But public health do not commission, and public health do not deliver. So what we do is we scrutinise the plans and the actions of others. We ask questions, we scrutinise, we challenge, and we support. We need to be prickly when you need to be and friendly when we need to be. That's another way of putting it. So immunisation in Birmingham is not where we'd want it to be. It's lower than we'd want it to be. And this is challenging for all ages and for all different vaccinations. And that means that as a city, the population is not as protected as we need it to be. For child immunisation programmes, uptake has decreased year on year the last 3 years. Now, yes, we have had a pandemic, but we were not, our immunisation and our vaccination uptake was not where we'd have wanted it to be before we went into the pandemic. So what we're looking at is how we get back and then improve further. Uptake for flu and COVID, this most recent season is also below expected levels. There's also a significant degree or high level of variation between the different programs. And even within one program, you have variation between groups, communities, and communities will be geographical, they will be by age. So some take more to immunisation than others, and therefore some are less protected and more vulnerable than others. You then layer on all the other things we know about people in our city, and the challenges and deprivation, and that increases the risk. Looking at children and young people specifically, one of the things that we particularly need to improve is we need to improve their uptake of vaccination. So this starts from antenatal, which is where we start to protect the unborn child and provide immunisation for those first few months of their lives, through to vaccination right the way through to about age 16, 17. So if we use MMR, so that's measles, mumps and rubella as an example, that is a particular focus of ours. We need to improve that. Vaccination there, uptake has fallen over the last 3 years to just below 80%. Ideally, it should be 95%. Now, we want everybody protected, going back to this population perspective, but we recognise that there will be some people for whom it's not appropriate for them to take that vaccine. It then makes it even more important that everyone else who can has had the vaccine, so as to protect as many as possible. We've also got a situation where we've got, not just by our size, but by scale and proportion, we've got more unvaccinated people, more unvaccinated children in Birmingham than we have in some other nearest neighbours and other cities that we might compare ourselves with. And as we've already alluded to, the level of poverty in Birmingham and other challenges associated with deprivation elevates that risk. So immunisation in adults, a particular priority for us is the uptake of winter vaccinations. By winter vaccinations, just mean flu and COVID. They are two separate vaccines, but because they can impact people, the same groups of people at around the same time of year, that is an added risk for those individuals, and it's an added risk for the health system that then has to deal with them. So for COVID-19, the number of unvaccinated people out of a 1.5 million population, that's Birmingham and Solihull, we've got more than a third who have not taken up their vaccination, who are not immunised. and not immunised in the context of COVID, if I use that as an example, means you haven't had your complete vaccination. When we were looking at who was in hospital, we had those who have not had any vaccination and those who've been partially vaccinated. So unless it's complete, you've not got the immunisation. You might have had some vaccination, but not the immunisation that we require. That's obviously to prevent hospitalisation and death, particularly in vulnerable adults. The other thing is that we want to keep our working age adults as well as we can. And that's partly because it's the workforce and the lifeblood of the city, but it's also because it's the workforce within health and social care that then also gets impacted from not having had the uptake of immunisation. So in our 50 to 64-year-olds, uptake is only 36 and 46% respectively for COVID and flu, not anywhere near where we need it. For the strategic challenges, Leah's going to talk us through, and then we'll wrap up and we welcome your feedback.
Thank you, Mary. I think just to broadly go through the 6 main strategic challenges. The first one we've identified is access to high quality data. What we've had from the COVID programme and through the COVID programme is just data around COVID uptake in communities where uptake is occurring to a greater or lesser extent. We don't necessarily have that available on a national or local basis yet for the same in the same way for other programmes. So there are some real challenges around that. Then when it comes to children's data, we tend to have a lag on the data that comes through. That's something we're looking to try and address locally, and we do have plans in motion to try and address that. In terms of strategic challenges around community links, what has been essential for successes, particularly within the COVID programme, has been effective engagement with Birmingham's communities to promote immunisation. That's been going on sort of throughout the lifespan of the programme. And we've got a lot of learning that we've taken away from that about the most effective ways to try and increase uptake, and how we really enrich communities and work with communities rather than trying to do to communities. That's utilising hyperlocal engagement through community centres, local meeting places, our mobile van offer, and others. But we're also aligning that with a more community engagement focus. So vaccines not necessarily front and centre, but part of a wider wellbeing conversation. And that gives us the opportunity then to overcome or sidestep some of the immediate hesitance and do some of that gentle myth busting, which can help. Really is about access to vaccination services. So if we go back to the 3 C's that Mary's alluded to in terms of convenience, complacency, the convenience element is very much in there. We have, in the most recent phase of the COVID vaccination programme, 90 sites locally, which is far more than we'd had in any previous phases. And that was trying to bring provision as close to the community as possible. We are looking at alternative provision for childhood immunisations and vax, and we're planning very much towards that to try and address an improved accessibility and convenience for parents and their children. Then we come on to vaccine hesitancy, which Mary alluded to. We do have communities, both geographically and across sorts of various demographic characteristics, where there is lower uptake in Birmingham, across Birmingham. But what I would say is hesitancy isn't a binary situation. It's not a yes or a no. It tends to form part of a spectrum of attitudes and beliefs. And rarely are those beliefs particularly extreme in nature, but they may often require a lot of engagement to really try and understand what's behind them and really sort of, I suppose, address some of those concerns. There's also the issue of pandemic fatigue, which has been recognised by the World Health Organization, and that has possibly fed into negative attitudes amongst some parts of our communities as well. So this will be pandemic fatigue from COVID, then stemming into other vaccination programmes. So as Mary had mentioned, we've seen a downturn in perhaps childhood immunisation and vaccinations. That'll be a parental-led decision by and large, but it might be influenced by the programmes and their responsiveness to that. We do know that partnership working and collegiate working, as Mary kindly said, is absolutely fundamental to this. We are trying to cultivate and mobilise as many community partners across as many sectors, health and non-health, as possible to really get that buy-in and support. And that might be employers, it might be community-based providers of non-health services, but it's really about sort of trying to get that messaging across. And I suppose the last one is around that tailored communications and marketing. It's really important that we can't take a one-size-fits-all approach to this, that we do have to have that tailored approach that reaches into our diversity of communities. We've had some benefits from using multilingual staff in terms of having effective conversations with residents and trying to help improve overall health literacy. Ultimately, I think it is about trying to get a good fit across a broad system with a lot of stakeholders with a lot of different backgrounds, and therefore you've got a really complex system as a whole in Birmingham when we come to comms and engagement. It's not as simple as just putting an advert on a bus, it's just thinking about how we enrich those communities.
So the next steps, as I mentioned, is that we're coming back in April. But before we do, obviously, really looking forward to the discussion that happens now. In April, the intention is that the paper from Public Health will focus on our assurance role and how we're able to, how we currently deploy that. And the ICB paper will be looking at much more detail at the delivery, planning and uptake. And then both papers will discuss the opportunities to improve and expand existing uptake improvement efforts with recommendations on progressing this work.
Okay, right, members' questions. Okay, we'll go down to the steps of Councillor Moore, Councillor Tilsley, and Mr. Pritchard.
Appreciate the report and I appreciate the challenge we're in. I think a lot of that is the rise of social media and the ease of spreading misinformation. Frankly, some stupid information, the idea that COVID vaccine, all that kind of nonsense. So it's very difficult to counter that because the people who do stuff. And I've no doubt that has impacted other vaccinations that are offered. So, but I noticed that unfortunately those communications are still happening on social media, but a lot of the messaging around, and I appreciate COVID fatigue, but other vaccinations as well in immunisation about trying to put more of that in social media to help try and reassure people, because otherwise if the only information you're getting is MMR causes autism or something stupid like that, then people are going to see, they're not seeing the consequences to help them make it, they should make an informed decision anyway. The negatives, you're obviously going to be swayed one way or another, and a lot of people do get their information active in Facebook. So I do hope as part of the communications and marketing, there is going to be some sort of element out there to try and put some positivity around what these programs can do. So my other question is around use of schools, particularly around trying to boost childhood immunisation. And perhaps not doing it in kind of like, because I imagine some parents, if you don't come and have a talk about it, so are reluctant anyway, probably won't do well. Whether they use of stuff like parents' evenings or school assemblies, actually come and talk about immunisation. But once you've got them there, then you can involve them and have those conversations.
Okay.
Have made their minds up already. I know the element that works, but there'll be some who are hesitant but won't make the time to go and discuss students at school or go to perform in the school assembly or something like that. Do people want?
So we can take that and I'll jump in afterwards.
Yeah, please. Thank you, Mary. So I think on the first point, in terms of social media, you're absolutely right, Councillor. You know, that has been part of the strategy as we've gone forwards, but I think there is perhaps more trying to. I think there is a real challenge that when beliefs have been quite embedded or certain sources regarded as trusted, you've then got to almost try and educate against why that source isn't trusted. So, but that is absolutely part of our planning going forwards. And regarding the parents' evenings, you know, I think that is part of the scope of our planning for what we call alternative provision. So we're looking to bring provision outside of the general practice, where as you say, for parental reasons in terms of working hours, availability, but also the kind of setting that it is. It may not be ideal for some parents, whereas a more sort of neutral sort of venue or something associated with the sort of their child's development, we can bring that in. But yeah, it's very much part of our planning.
I was thinking more from not necessarily those parents who will go out of their way to have those conversations, but would have them if you call them. So it's about trying to engage with those, because some parents are obviously very keen and think about these things, but sadly there are some where it's not a priority or they're concerned. But and I think sometimes, particularly with the anti-vax thing, sometimes there's you have anti-vax views, but you're embarrassed to have those views, and therefore you're not willing to air them, and therefore not willing to engage because of all the negativity that anti-vaxxers have quite rightly got. And other ways to reach those people, and I just wondered if parents' evenings and such like that might be a way to do that. They're not there to discuss it. Generally watch or some of them.
I think it's certainly considered an all such. Part of you mentioned schools, and so what I wanted to mention was some work does need to happen before schools. I see immunisation as something that should be a standard and expectation with regard to school readiness. We're getting people ready for school so that they have minimum days lost to vaccine preventable diseases, amongst other things. So the conversations that I'd want to have with early years settings of all sorts to raise the expectation that it's a standard that children are protected at that stage. Schools would be great for mopping up the people who transferred in or who one way or other haven't had it, and then it's parents there, absolutely. But I think a lot of the work, particularly with child immunisation, we've got about 5 years to work on them, and schools have an awful lot thrown at them. So I'd want to do much more with early years, and I think there's an opportunity for the council. I know not all early year settings come under council control, but I think there's an opportunity for the council to influence in terms of the standards that are expected for safe early year settings for our children.
So you have one comment and two questions. Comment. I think it's great we're doing this work. I'm really looking forward to the detailed papers coming in September. Is it September or is it April? Brilliant. Oh, that's even better. I recall when Dr. Justin Varney arrived as our Director of Public Health in early 2019, he briefed the committee and I think tipped off his concerns about low levels of immunisation at that point. So it's great that we've now got, beyond COVID, as it were, quotes, onto that issue, that broader issue. So it's really good. Second point, this is a question, to make sure I understand the difference between immunisation and vaccination. Let's take the COVID figures. A third of the population are not immunised, is that correct? They may have taken one vaccine, but they haven't had the whole programme, all right here. So we're saying that it's a third who've not completed the full cycle of vaccinations in order to be immune. Have I understood that correct?
It would be a third of the population who have not completed the full.
They might have had one jab, but not all three or four or whatever.
So
Yes.
it's the non and the partials.
Right. So within the third, there's 500,000 people. Some have had no vaccination at all, and some might have had one jab here and there, but not the full whack. I've got it understood. Right. Okay. That's good. I understand that one then. Final question. It's helpful that you've tried to clarify who does what, but I'm not quite been clarified yet. During COVID, Birmingham Public Health was front and centre of the work being done in communities to build the uptake. It was an action engaged, if you like, on the front line by the Public Health Unit Department of the Council and its partner and its collaborators. In your presentation, I read it that Public Health don't actually have an operational role here, that NHS England are operationally running the programme, and the job of Public Health is to kind of oversee it and scrutinise it, but not actually to go out there and do the work. So if that's my understanding right, question is to NHS England, who are your boots on the ground? Who are the NHS England workforce out there doing the campaigning and lobbying and persuading and going to school, parents' days. If it's not NHS England, who is it? Because I'm quite confused here. Thanks for trying to clarify it, but I think I'm more confused now as to whether Birmingham Public Health actually operationally run the campaigns, or whether NHS England has a kind of its own little task force of workers out there doing it. Please clarify.
Councillor Pocock. I think I can probably give you some assurance. So, we continue to work as sort of colleagues. We had a vaccine confidence programme that ran last summer, which was led by the public health team, and that was direct community engagement there. Just to clarify, myself and Paul, who's on the call on the screen, are from B rather than NHS England, just to have that point of clarity. From our side of things, we have inequalities engagement leads within our COVID vaccination programme team, and we utilise them not just for COVID engagement, but wellbeing and other programmes engagement as well. So add to that, we've had some support from the UK Health Security Agency in the form of street teams, which visited in December. We've taken learning from those. They had conversations in lower tech communities. We're able to really sort of take some of that messaging back, which is where we're starting to get some of that dialogue coming through. We're looking to replicate that and sort of do our own sort of delivery of that going forward. So there's multiple strands going on, but it's definitely in partnership. Well, no, sorry, in a collegiate approach rather than the partnership approach. I think safe to say, that I don't feel our public health colleagues have sort of stood back. Looking side by side throughout this.
Yes, I mean, the government has been very clear in terms of where they've given the responsibility to the NHS and within the NHS system. But there's also recognition that the local authority has really good relationships in all manner of places, and we will share the benefit of that. Sometimes we're doing an introduction and an ambassadorial role, here's a connection. Other times we're doing a piece of work, can you give us the message, and we will deliver that message. So we're going to use the opportunities we have as a system, but the responsibility for the numbers and what we're able to achieve, having done all of that, is for the NHS system to give an account.
Yeah, we'll take Councillor Moore's great idea of going to a parents' evening. Who's going to go and do it? Who is it who employs the people who will go out and chat to parents?
So, as I say, as part of the COVID vaccination programme, we do have inequalities leads and staff within that team that we utilise for this work, but not purely for COVID related conversations. We're looking at that all ages conversation and wellbeing conversation.
These staff in a team that are employed by.
Currently, so the arcane. Do apologise. The lead employer for that team is University Hospitals Birmingham. However, the team effectively is managed by the ICB in terms of the oversight and management that we provide.
Work for the UHB and are accountable to the ICB and not to Birmingham Public Health Directorate.
Right, but if we're going to have a conversation, people, depending on the relationship, and we in public health have a relationship there, whether it's recognition of the director or the rest of us who've been working behind the scenes, we will use that relationship to open the door and start the conversation. And then we'll bring in the relevant experts. So very often, even where public health does go and sort of appear to lead things, there will be, an NHS colleague, a GP, somebody from private care, right beside us saying, oh yeah, and here we can answer all the practical questions that people may want to know.
Let's come back to that as this service evolves. We'll have a look at exactly who does what.
Thanks for the presentation. It's been really useful. So just a few questions on the number of unvaccinated or the levels in Birmingham Solihull. It says third of the population. Now, is that of those? Is that total, or is that also including people who were not eligible or we weren't giving the vaccines to? Because obviously certain age groups, like young children, weren't getting them. So they wouldn't have received them. So if you're counting, you're saying that they're not, yes, technically they are, but they weren't offered it in the first place, if that makes sense. So I'm just, in terms of when we say unvaccinated, are we meaning the absolute total, including people who weren't eligible for it, or are we meaning the people who were eligible and didn't have it? So that, just to clarify that a little bit, because obviously that's a little bit of a difference, because to me a third sounds a heck of a lot in terms of the promotion proportion and those raw numbers. But if it's including people who were never going to be offered it anyway, then that's a slightly different slant. And kind of related to that, what are you defining as unvaccinated? Because I've only been eligible for 3, and myself because of my age and kind of particular circumstances, whereas other people might have been eligible for 4 or 5. So are we saying I am unvaccinated, or are we saying that I am because I've had all 3 that I was eligible for? Again, just to kind of clarify that a bit, because particularly with COVID, there's different numbers of jabs and different of course, different parts of the population. And then, have you got any more figures other than the NMR one for a clear increase in hesitancy or decline in take-up of different immunisation programmes as a result of COVID-related vaccine hesitancy? And can you link those clearly? Because I suppose is some of that linked to the type of vaccine? Because some of the vaccine hesitancy around COVID was because it was a new type of vaccine, it was a new technology that had been done. Well, that's some of the stuff that was being tried around. I know not everybody was necessarily as nuanced as that, but is there a link there? And are more established vaccines holding their ground a bit more in terms of the levels of take-up? And my final question is, on the MMR front, obviously there was a dip in the 90s and noughties when we had that scare around autism. Did numbers in Birmingham Solihull go back up after that, after they went down? And are there any lessons from that we can apply now? Thank you.
Answer at least the first 4. I think the 5th one I probably will throw to Mary, if that's okay, Councillor. So in terms of those numbers, that absolute picture, we have something called the Evergreen offer, and the Evergreen offer is if you are eligible for a primary dose, you can come forward at any time to have that first dose, then 12 weeks later have your second dose, and then your primary dose is completed. For some people, they do require a 3rd primary dose just to underlying conditions. So that number we talk about the unvaccinated, are those that haven't had that second dose onwards of their primary dose. I hope that clarifies that. Okay. So in terms of the full course, a full course would be your primary course. Supplement to that would be the seasonal boosters that we've had. You may miss a seasonal booster, but you've had your primary course, barring certain conditions, you still consider to have a full course, but then you top it up with that seasonal booster. What we anticipate is there will be a spring seasonal booster for a limited cohort for COVID this year. There'll be likely an autumn seasonal booster again, and then we expect it to become seasonal alongside flu in future years. The next one around childhood uptake, I think is something we're going to bring back to the April board meeting, where we have the more detailed papers. MMR, I suppose, is because it has been a headline, which is why we picked that out, to sort of help understanding. But we have seen a decline in most of the areas. However, what you see alongside that is that might be based on a percentage. The real terms is if we've seen an increase in the number of children, then those children may see in absolute terms, in real terms, an increase rather than a decrease, if that makes sense. So there are nuances to the data. And whilst I'm speaking about children, going back to that vaccine eligibility, children aged 5 upwards are eligible for COVID vaccination, so they can come forward at any time. So when that child reaches 5 years of age, they can begin their primary course of COVID. So that eligibility is always in scope because of the Evergreen offer that we have. And then in terms of vaccine types, I think this tends to impact flu more than anything, because there are certain formulations of flu vaccine which are egg-based, which for some people that becomes a no-no. But it's also about the vaccine types which are recommended and preferential depending on age of recipient, underlying conditions. I think it's hard for us to draw a specific correlation to any one causation from any one vaccine type to pandemic fatigue. However, what we can draw is kind of a loose correlation that we've seen that, and it is what we're hearing back from communities through that engagement work that we've done. In terms of longer term mental MMR from sort of Birmingham's experience, I am going to go to Mary here as the expert.
So yes, we had the misinformation incidents, and that's affected MMR across the country. There's a lot of work over many years to sort of recover. I don't know where Birmingham was before that incident, but whatever recovery they had achieved before COVID wasn't yet where it needed to be. And so if you think of it as something that's heading up, not getting to the 95%, which is where I want it to be. And then since COVID, it's dropped down. And some of these vaccines were continued to be on offer. So it's not like, oh, COVID came and we stopped everything. There were some parents who still, took their children, presented for vaccines during COVID. And since we've sort of opened up a bit more, everything's available. But what we haven't got is the demand side of it. So we do a lot of work on supply, but what we've got to do is to find a way to create a demand in our communities that people are wanting the vaccine and taking it up. We're not getting reports of people wanting a vaccine and not being able to have it. We're just not getting enough people wanting it at the moment. And I would agree with Leon. I think it's really difficult to say COVID has caused this. Because if you take COVID out of the equation, the trajectory was not sufficiently steep. We weren't in a great place beforehand. So COVID has just delayed our getting there, would be the best case scenario. But what we really want to see is that there's a demand for vaccine. And I think that's, we continue to work on the supply side, but I think there's a lot more work that we need to do together on the demand side of it.
Thank you. Councillor.
It's not questions, it's more comments, because I am very, very disturbed by the immunisation figures, particularly if we take MMR. We're down at 78.7. Now, to protect an outbreak, particularly at 95%. And I think if you go back 5 years, they had a severe outbreak in London, and there were a number of infant deaths because of that. Of course, the problem is that it's never going to affect you, is it? It's always something in the immediate, and suggested with schools, but I'm sure that in London they had that, and I see in London, in the northeast London, in the boroughs in the northeast of London, immunisation has dropped down to 60%. This is a real issue. It could be, the reasons could be cultural, they could be religious. I'm aware of, as far as COVID is concerned, that a certain theory was imported from North America, that the vaccine for COVID was a product of fetuses, and that affected certain religious groups who wouldn't touch it with a barge pole. But we're dealing with such a complicated set of issues across the world. If we look at smallpox, polio, MMR, this is all a conspiracy to reduce population. But we've got to deal with these problems because measles is still a killer. I remember as a child being taken. If a kid in the street had measles, there was a measles to try and ensure that the parents were trying to look after them to make sure that you were protected in later life. And of course, it does affect fertility if you do catch measles, can do. It's comments. I am worried. Now, I was a COVID champion, and I used to send out a weekly update to people on my database. And I got so frustrated about the level of immunisation. It wasn't particularly in my ward, but it was in general, that I started to introduce the death rates that were happening as well. Of course, it does happen, and it was real. And it was largely people who were not immunised against COVID who ended up as fatalities. So we're dealing with a whole range of issues. And I am concerned. Yeah, COVID was just the first of what I think is going to be a number of pandemics, because they're out there. We just haven't engaged fully with them yet. And if we can't engage with the population, I think we're just storing up an immense problem. And let's face facts. What COVID has done to the health system in the UK, with delayed admissions, delayed interventions, it's just horrendous. And if we don't get ahead of the game, we are going to be caught severely. So, as I say, they're just comments, but I am extremely worried about the situation.
Yes, I think we try to start in reverse order. So a big chunk of the impact of COVID on our city was due to the baseline health of our citizens. And that impacted the resilience they had. It impacted whether they had to go out to work, what they had to do for a living, etc. So the biggest thing we could do in terms of preparing for the next pandemic, and I can reassure you that we are preparing for the next pandemic already. We do not know what it's going to be, or how soon it might come. It might not be a decade, it could be sooner. We are monitoring what's happening in other parts of the world at the moment. But the biggest thing we could do to give Birmingham the best chance of dealing with the next pandemic is to get the baseline health of the citizens in a much better place. Part of that would include getting them immunised for the things that we know we can prevent. With regards to measles outbreaks, I've had the misfortune of having to deal with measles outbreaks in Wales and also in North London. And you quite did have issues that partly cultural, not so much religious, although it appeared that way. But this is where you have to get talking to communication, talking to and listening to the communities that are not taking up the vaccine. So when you're talking about that, basically, there's an offer out there, there's amount of supply, there's provision in different ways. But what we're having to do for those people who are not immunised at the moment is we have to work a whole heap harder. So for some people, you just put a message out there, they respond. And for other people, you need to have a conversation. And for some others, you need to have several conversations. And those conversations are not just from healthcare professionals, it will be from their communities, etc. Using North East London as an example, we worked with a particular religious community. And so what was the obstacle? It was where people went, and they went with all their children. We took the vaccine to them. They, the community, persuaded others to take up the vaccine. It was me. And we did get on top of the situation and we ended that outbreak. But what we realised is that it wasn't that they didn't get the message, but they weren't going to take all 6 children or 5 children. They tended to have very large families to wherever the vaccination was required. But if they happened to be there when it was being done, and this is a cross-border issue, I was working in Haringey, and it was a Haringey-Hackney issue. And we couldn't do things by borders. We had to recognise if that's where the people go and they're going to be there on a certain day, we take it to them. But we only found that out by having those conversations. So it's recognising that it's not that what's currently happening we need to retain. What more needs to happen is going to require a lot more engagement, listening, and then responding in different ways to reach more of the population. As Leon said earlier, there's a spectrum to vaccine hesitancy. And what we don't have a lot of in Birmingham is the out and out no, which means that actually, if we can find out what it is, we can convert quite a few of those on that spectrum to taking some of this. And it's an ongoing thing because you do it for one vaccine, then you do it for another program, until we have established a culture and a habit of we will take up, vaccination when it's offered because we want to be immunised. I think that's probably I'll add at this stage. If you're a COVID champion, I hope you're continuing to do some engagement because we need our COVID champions to continue engagement. This cannot rest with a small number of health professionals or other professionals. We need the community voices saying the right thing to people, nudge, nudge, all of that required. So thank you.
There was information and statistics that I could actually pump out. There aren't anymore.
Some people will be persuaded by information and statistics, and the other people are swayed by who they
gives you a coat hanger message.
We can develop MMR coat hangers galore.
Send them out.
Thank you for that. I got a question myself. It's about immunisations rather than vaccinations,
Okay.
sort of predates COVID. Seen some information from the BMA saying that immunisation rates have been declining in England since about 2012, 2013. I suppose, and we're well below the 95% WHO recommendation. And apparently we know the UK is no longer classified as being a measles-free area. So is that correct or not?
We need to see that information to see whether that's correct or not. I can say that the uptake of vaccination has not increased in the way that we'd have liked it to. We have, there will be many reasons for that. But what we have is we have a society broadly who, they saw COVID, they saw what it meant. Oh, okay, so some of them will take up the vaccine. But for things like measles, there are people who've never seen a measles case. I did in my early careers, treat lots of measles cases. So there is a degree societally of complacency that these are things that happen in far-flung places of the world. And then when it does happen in the UK, well, it's somewhere else. And my concern is that when it does come to Birmingham, the uptake is not even across the city. So it's going to land in certain parts of the city rather than others. And we have a responsibility to work on that.
I'll show you this information when we've finished if you want. It also goes on to say that for Ireland, for Scotland and for Wales, they've managed to maintain their immunisation rates at 95% or about or above. And I was wondering if this information is correct, why you think that tends to be an England issue as opposed to a UK issue.
So Ireland, Scotland and
Wales.
Okay, so I can tell you from the last, so you're talking about 2012 onwards, we've had outbreaks in Wales. I felt it. So every place is working hard. If England is behind, I want to understand what's different. Obviously, we've got different communities, different ways of doing things, but the offer is there. So it's, this is one of the interventions that is nationally funded. So it doesn't matter what's going on with our budgets, it's funded. We've simply got to take it up. If we didn't have bins collected for, bin collection felt as 78%, we hear about it. We need our community to be equally engaged about immunisation. How? There's no simple, easy answer to it. We will look to Scotland, we'll look to Northern Ireland, we'll look to the Republic of Ireland, but we've got to find a solution that works for Birmingham. And there are some parts of Birmingham, and there are some general practice, because we can see data by GP practice. There's some parts of Birmingham where the uptake is at 95% or very close. And there are some places where it is lower than 78%, if that's our average. In the same city, with the same systems, sometimes in areas that are very close together. So there's a lot more to understand about how and why uptake is better in some places than others.
So you wouldn't necessarily think there was a need for a sort of national campaign about immunisation.
I'd
It's
love
about
there to
targeted local one.
I think I'd love there to be a national campaign. My concern is that the national campaign will reach probably the people whom we have already reached. And I think we need to look at what we need to do locally. Now, there is some national strategy that's coming out later this year.
Yeah, we were expecting it before end of year 2022, but we've been told imminently for a few months, unfortunately, Chair.
So when that comes out, we still have to look at the local implementation of that strategy. And it will come down to, you know, why does my neighbour want to take up vaccination and why does the other neighbour not want to take it up? I think this is the easiest stuff has been done. We now need to do the hard lifting.
Last part of the question would be in terms of, do you think we're a bit restrictive in terms of where you go for your immunisation? We need to be opening that up in terms of maybe I could go to the pharmacy, maybe we could go to a religious centre, maybe if we go to a community centre to get those if they're available at that particular time, rather than going to the ones that you would traditionally go to when I was having my immunisations, which is you went to the doctor.
We can certainly look at offer. The first thing I'd say with the offer is making the public aware of what the offer currently is, because I don't know that everyone is aware of all the options that are available. And then we need to know, well, what additional is required. Now remember, whatever is additional that's required is required at a cost, probably moving the resources around. So if that's going to give us the yield, which is what we did with COVID, we put things in place for that. Is that sustainable? That would be another question. But if the offer that is out there at the moment isn't known about, then that's the first thing I'd want to do. The second thing would be to find out, well, okay, so what is the proposed offer that someone else would like? But I think my concern about discussing offer only is that it deals with supply, and we need to look at both demand and supply.
Just a follow-up, really. It's been an interesting discussion. Mary makes exactly the points that Dr. Varney made when he first introduced this. This is a major potential source of health inequality in this city. And so in the papers that are forthcoming, I think that would be really helpful in detail, geodemographically, across the city. Let's take MMR as the issue, and Councillor Tills has already highlighted why that might be now our focus. If we can get some data on uptake by ward and by demographics, I think we can then start to be partners, if you like, and the collaborators in getting the right messages out. And I do recall during COVID, when we had the weekly data, Councillor Idris and Councillor Zia Islam were on this committee, were really front and centre with their own communities, taking that information and working with those communities. It really helped them focus their work. And I think we might need to do the same with the resource that there is amongst city councillors here to be part of the communications and engagement channel. I'm pretty sure that resource is up and ready to help. But we need that micro level data. And hopefully in your reports, I'm looking at Mr. Sheriff, you might be helping to write them. The reports will contain that granular detail for Birmingham that we can then use in our local communities.
Is it possible to take the data
Data sets, yes, for others, not so much. So for COVID, it's a little bit easier, simply because of the the infrastructure, the data infrastructure that we have, that we access. For other sets of data, they tend to be linked, as Mary says, to particular general practices. And those general practices will draw from the geography, not just around the general practice, but from further afield. So we can kind of make some proxies, and that's absolutely something we will do. But we can't definitively say for this ward it's exactly this, if that makes sense. Yeah.
Got Paul Shea wants to come in at this point.
Yeah, thank you, Chair. It's quite a challenge following the conversation online. So I won't go over some of the ground that's been covered. I think the points have been incredibly well made and are helpful. We can give some thought to the data, Councillor Pocock, about how we might provide some of that perhaps in advance of the formal committee meeting. So we could almost identify any key lines of inquiry in advance. So we're coming in to have a very focused discussion rather than just kind of pulling the data apart, so to speak. I think there are some real challenges around roles and responsibilities. I think we have a number of organisations that are committed to working together, and I know this was something that your colleagues were looking to tease out in the earlier part of the discussion. I think there's much more work that needs to be done here, if I'm being candid. I think we are working well together, both City Council colleagues and NHS partners, and we do work well with NHS England, but there are changes afoot into how the NHS is structured, as is always the case, seemingly every few years, and that creates disruption. We have to be really focused that that doesn't have a consequence or impact here, given the ground that we have to make up in terms of improving uptake. So I won't go on any further, Chair. I think we need to bring back roles and responsibilities, how we make every contact count across all agencies, how we use your support and community networks to get some of those messages across, and perhaps Mary, Leon and team, if we could give some thought as a debrief to this session about how we focus that conversation in April, I think that might be useful, and happy to have a pre-meet, Chair, if you feel that would be beneficial to get the most out of that session. Thank you.
Very useful, thank you, Paul. Councillor Pritchard.
Yeah, just to follow up very quickly on that data thing, and I take your point that it's difficult as a general practice, and that's where most of the data sits. But another thing I chuck in there is sometimes even ward level is too broad. Within wards, there'll be differences of demographics in different areas. So if it were possible, you could go further than say by local output area or mediumship output area, and if that were possible, but it may not be because of the points you made.
Can for COVID.
Yeah.
Can't for others, unfortunately. COVID, I could rattle on all day about the lower super output areas, not a problem. But unfortunately, and this is what we talked about earlier in terms of those challenges that we have. We don't have the same level of richness behind non-COVID programmes as we have for the COVID programme in terms of data.
I suppose, yeah, whatever you can do on that level for the day, and I accept that it's not available. The other point I quickly make in terms of the follow-up to actually the discussion between Councillor Brown and Mary just before was, I suppose from where I was sitting, I would see taking the vaccines to where people go, which isn't a traditional setting, for me was part of more creating the demand than the supply, if that makes sense, because it's part of, I saw it as part of that education information piece and saying, well, actually, and improving the access piece, not necessarily making sure we've got enough doses kind of side of it. So I kind of saw it more that way and in that sort of context. And related to that, my final question would be, you say the budget is fine. Let's say there was 100% take up and suddenly lots more people were getting jabs. Would the doses still be there in that context if the marketing and communications and the reach to communities was as good as you would hope? Would there then be a supply issue? Because there's no supply issue at the moment, but as you said, the rates aren't quite where they should be.
So I think we can split that supply demand sort of question into two. One supply, I'd probably frame it as capacity. What we have is plenty of capacity in the system. We've never fully utilised our COVID capacity, for example. We've never fully utilised our flu capacity, and I think Paul will want to come in a moment. It's that demand generation, that demand stimulation. We've gone into every community we can think of, and we will go into more. We're always seeking new opportunities where we've taken our mobile vaccination units, etc. We've gone into communities to have conversations, so not even to take vaccine with us, but just to have those initiated conversations. had the street teams going into sort of more different areas. We've had the vaccine confidence programme, which ran last summer. All of those are going out. So we're doing all of those things to try and generate demand. When we take a van out, for instance, we do a 2-week lead-in campaign in terms of comms, but ultimately it comes back to our capacity outweighs our demand. Paul, I don't know if you wanted to add anything to that before I come on the next point.
I think it would be useful to bring back the resources element next time, Leon, if colleagues would agree. I think we've had non-recurrent short-term funding around COVID vaccinations. That significantly reduces as we move to the financial year 23-24. So there's a significant reduction there, and that means that we have to re-engineer our programme. The initiatives that Leon set out and Mary still exist, but they are tapered. We do have a real challenge to work through. When we talk about childhood immunisation and vaccinations, we're talking around they're predominantly delivered by GP surgeries. And actually the way those are resourced is comparable across wherever your surgery is. So surgeries in some more of our affluent parts of the city will have less of a challenge based on the data I've seen, evidently, where families will come forward with their children to perhaps more deprived parts of our city. If you're that GP surgery with all the other demands that are placed on you, many of which have been debated in other fora, it's a real squeeze. So what might be a 5-minute task or a 15-minute task in one surgery could end up being the investment of a couple of hours. And those are very real examples. They're not, I suppose you could argue they're anecdote, but I've gone and spent time, as has Leon, in a number of our surgeries across the city. So I think we do need to bring back our resource plan, and I think we need to bring back how we're mitigating some of those risks to you.
I just wanted to pick up on the point about that's been mentioned and that Paul's raised around roles and responsibilities. I'm just conscious from the diagram, there's the public health and the local authorities sort of around the table, and ICS colleagues, but whether at some point it would be useful or helpful to engage with NHS England as the commissioners of the service, and perhaps that's a conversation to have outside of the meeting.
So to engage them to get work done.
To understand for them to be part of this conversation with members, to explain yeah, well, I don't know, either here or to get some information from NHS. I don't know, I'm just conscious that there's a big part of the system that isn't around the table as part of this conversation.
Very closely with them, very closely with them. If you'd like them here, I'm happy to convey that request. But I mean, we're working with them weekly, and ad hoc as well, to have conversations to move things along. So but they are a very small team for a very big patch, which is probably why we haven't asked them to tag along today. But if you'd like to meet them, we can.
I don't know. It's a question for members, really.
It would be helpful to have as many parties to in the game as possible.
Do you want to mention something yourself?
Yeah, just to sort of add to what Mary was saying in terms of that ongoing engagement with our NHSE colleagues. They have representation on our system-wide immunisations and vaccinations programme board. We've worked with them to develop particular offers and opportunities, which we hope to go live this year. And they're also leading our childhood IMS and childhood and adolescent immunisations and vaccination board, project board. They chair that as well. So they're very much entwined into the system. We meet every 2 weeks to discuss the COVID programme. And we have regular meetings around how we can really address inequalities, within vaccination programmes as a whole. So there is definitely that ongoing. I just want to just give assurance really that there's not a disconnect there, if that makes sense.
And I'd add to that and say that the NHSE is also on our Health Protection Forum, which reports into the Health and Wellbeing Board. We meet every month, and we have additional meetings and sessions in between to progress things. So, but yeah, we'll relay that to them.
I think if you could relate, because like members would possibly agree that an NHS presence periodically might be beneficial in terms of discussion immunisations, vaccination programmes. We're all done questions-wise? Yeah. Okay. Can I thank you all for your presentation? It's really useful, and for answering the questions. Thank you.
Thank you. Okay, I'll have a look. Thank you.
Okay, thanks.
Recording, I'm not in the meeting, I haven't. Have we stopped recording, Val?
Yes, okay, Fiona, I'll do that now. Thank you.
Thank you. Oh, sorry, Val, sorry.
We-
Sorry, Val,
Yes.
no, the meeting's continuing, sorry.
Okay, I haven't done it yet, so,
Sorry.
okay, carry on.
Before we press on to the work programme, I've been reminded that we omitted to agree the minutes from the previous meeting. So are people happy that we agree them? Have people any questions you want to raise regarding them? No, okay, so we agreed with that. So Fiona, over to the work programme.
Yes, sorry about that. I was so carried away with that presentation. I just thought that would be fascinating. But yeah, I forgot the final items on the agenda. So the work programme, it's yeah, coming towards the end of this municipal year. So the work programme sort of coming towards the end for this year. So for the meetings in March and April, if I can just get myself down to the right slides. The meeting in March, there's a presentation from the ICS and UHB. Sorry, that's a joint task. Sorry.
Joint task.
March meeting for this committee is yeah, day opportunities, Q3 adult social care performance monitoring and the cabinet member update report. That's for the March meeting, and then for April there's the ICB update, and then the more detailed report on immunisation that's been discussed at this meeting. So those are the two meetings coming up towards the end of the municipal year for this committee. Then on the inquiry that this committee is a lead committee for working with the members from the Education and Children's Social Care Committee on children and young people's mental health. That work is progressing. There's a number of meetings that have been set up. There's another Task and Finish group meeting this afternoon. Having spoken to the Task and Finish group meeting and previously discussing it with the chair, the aim now is to report that inquiry to the July council meeting. So just extending it for a month, because there's been so much work involved, and particularly making sure that there is engagement with young people during the process, and working to sit with colleagues from FDB to set up a meeting with young people to make sure those conversations take place.
I just want to say we've got on the 13th of March, we've got the joint task meeting here, which will be looking at the ICS update on the reviews, West Midlands Ambulance, and the BSOL update on finance and recovery plans. And then to add on to what Fiona was saying, on the Tuesday the 14th of March, on the day opportunities, we've also got representatives from the Empowering People's team who will be physically here to give some verbal feedback. So thank you all for that. The date of, well, anybody, any questions to ask on the work programme? No. Getting time, the next meeting is Tuesday the 14th of March at 10 o'clock. Any requests for call-ins or petitions? No. Any other urgent business? No. Authority to chair? Thank you all for your time and questions. It's been appreciated.